What we're aiming to do here is to give you some insight on what happens when an inversion type ankle sprain occurs. And hopefully by the end of this presentation, you'll have a solid idea on how to manage an ankle sprain with the help of your doctor. What you're going to see here is what we as physical therapists typically prescribe and how we guide our patients through the process when such a type of sprain occurs. So I'm going to start off this presentation with a quote that I heard from a very wise osteopathic physician who was lecturing on ankle sprains at a course that I took many, many years ago. This quote stuck with me because it's a simple quote and frankly, it's the truth. There is, in fact, no such thing as a mild ankle sprain. And what we're going to see in a few minutes is that ankle sprains will very often heal up nicely, but ankle sprains can also often leave us with problems that, if not addressed, can have long-term negative consequences on us. So here we have a nice stock photo of what an ankle might look like after a what I would call a nasty inversion ankle sprain. Note that we have a nice view of the lateral or the outside portion of the ankle here. I've circled the area of the ankle where the lateral collateral ligaments can be found. Here in the photo, we can see extensive bruising in the lateral portion of the ankle, and we can also see that the bruising extends up a bit into the lower leg as well. So I want to mention here that there's another type of sprain, and it's called a high ankle sprain. It's HIGH, as denoted in the slide. And a high ankle sprain involves a ligament that runs between the fibula and tibia bones in what lay people would call the shin portion of the leg, which of course is located above the ankle. So this type of sprain is usually a bit more serious and involved, and it typically takes a longer time to heal and to rehab. So if a lot of your pain is clearly in the lower part of the shin, which is located above the area that I circled in the photo, I would definitely take this as a sign to go and see your doctor and get an x-ray. So I was very excited to find this great little video here online that shows exactly where two of the main ligaments that are involved in these lateral ankle sprains are situated. So you can see here in the first half of the video feed, you can see the two main ligaments that attach from the fibular bone, which is the long and thin bone that runs down the lateral aspect of the lower leg or the shin, onto the bones of the ankle. So you can see those two ligaments there. These are the lateral ankle ligaments, we'll call them. In the second half of the video, you can see that the virtual camera kind of changes perspective and shifts over to the other side of the ankle where the medial ligaments lie. These ligaments on the medial side are referred to, by the way, as the deltoid ligaments. And I would say that they are usually not involved with a typical ankle sprain. Because if you think about it, when you turn your ankle, it's turned inwards, and that will not typically strain the ligaments that are on the inner portion of your foot if you think about the mechanics of it. Also, though, if you did happen to sprain the deltoid ligament, you could still rehab it in a very similar way to the way that we're going to show you in this presentation. So do not fret. And in case if you're wondering, by looking at this slide here, an inversion ankle sprain looks like that. As we saw from the last slide, the ligaments on the outside of the ankle with this type of sprain take quite a beating, and they can become stretched out or otherwise damaged when that ankle twists like that. In extreme instances, the ligament can tear, or the fibular bone, which is that bone that runs down the lateral portion of the shin, that bone can fracture as a result of the sudden high amount of force. So we will often see with inversion sprains swelling and sometimes bruising along the lateral aspect of the ankle. And by the way, if I hadn't mentioned before, if you sprain your ankle and it does bruise up, to be safe, it's always recommended from my vantage point to see your doctor, just because there's always the possibility that you could have sustained a fracture, and the only way to really tell if that's happened is with x-ray. So let's talk about the actual properties of the ligament or ligaments that are sprained during these type of ankle sprains. So I like to use the comparison of the plastic that surrounds a six-pack of your favorite beverage when we talk about the ligaments of the ankle. Once the ligaments are stretched out with a sprain, they really don't go back into their original shape. Just as the plastic that surrounds a six-pack does not go back to its regular shape when you pull on it. And as you can imagine, this can become problematic. Ligaments have neural connections to them that send signals to our brain that tells the brain when the ligament is in a stretched position. And the brain then tells the surrounding muscles to make adjustments to get that ankle, into more of a safe position and out of a danger position. So if you think about it, if the ligament is stretched out from a sprain, the signals that are sent to the brain become delayed and a little messed up. And even if the delay is a little amount of time, it only takes a fraction of a second of delay if you're playing sports or something like that in order for you to re-sprain again. So this is not good. It's once you sprain your ankle, it's much, much easier for you to re-sprain that because of the positioning and because of the state of the ligaments. So in my humble opinion, we're left with two potential problems here. The first problem is what we just described. A delayed neural signal that results from stretched out ligaments causes a delay in the body's protective reaction to stepping in, let's say, a divot on the soccer field, for example. The second problem is something that most of us wouldn't normally think would necessarily be a problem, but it is. Some of the other joints in the ankle can become stiffer in the long term due to the initial trauma of the ankle sprain if they are not appropriately dealt with. So when these other joints become stiff, it can often become more difficult to what we physical therapists call dorsiflex the ankle. So if you look at the photo that we provided here, this ankle is moving into the dorsiflexion range of motion. Picture this person sitting down on a chair with his foot on the ground in front of him. The arrow denotes the direction of movement of the foot, while in this example, the heel is staying on the floor. So if you kind of take this into more of a movement type scheme, that ankle, picture it moving up into that dorsiflexion position. It's easy to tell, by the way, if you have lost dorsiflexion in a sprained ankle. Just compare how much you can move the sprained ankle in that direction to the other side. And if you see that you can't bring those toes in the front of that foot up as far, you have lost dorsiflexion. Now we're going to switch our focus a little bit onto the treatment side of things. So, in a nutshell, how do you go about treating an ankle sprain? The first step is to address the acute phase of the injury. So you guys have probably all seen the acronym RICE before, RICE. This stands for rest, ice, compression, and elevation. So this should be done, in my opinion, for at least the first week following a sprain. And of course, this depends on the severity of the sprain. The rest and the icing are self-explanatory. I generally do not ice for more than 10 to 15 minutes at a time. This can be done several times a day, by the way, as needed. In terms of compression, using an ACE wrap from the drugstore and circumferentially wrapping it around the ankle provides a nice amount of support and stability and provides a little compression as well. Elevation will also assist with allowing the swelling to drain. And one last word to the wise, there is a grading scale to ankle sprains, or grade 1, grade 2, grade 3, etc. A grade 1 sprain will typically not look so bad. There may be a bit of swelling and some pain. Those can typically be managed pretty well. Higher grade sprains, the 2s, the 3s, etc., that involve bruising and increased amounts of swelling and pain, you've got to be a little more careful. I hate to be overly repetitive here, but as I said before, my advice to you is to see your doctor, particularly if there is bruising involved, or, and this is the big one, if it's really difficult to place weight through your leg. If you can't place weight through your leg well after an ankle sprain, definitely see your doctor. If there is an ankle fracture, we need to know it. And like I said, there is no PT out there or doctor for that matter that has x-ray vision, and x-ray is definitely the best way to find that out. So step 1 was our rice. Step 2, as you can see here, is starting with basic movements in resistant or resistive exercises. And the first round of exercise interventions are pretty basic, and if you tolerate them well, you can start these pretty soon after an ankle sprain. I would say most people probably will start with a grade 1 or perhaps a grade 2 sprain 1 to 2 weeks after the sprain. They'll begin some of these. We're going to show you some videos in a second, and you're going to need a towel and some elastic resistance bands, and you can find tons of elastic resistance bands online. They're very, very cheap. We're going to show you now how to do these basic exercises of towel gathering, resisted eversion, inversion, dorsiflexion, and ankle pumps. So let's take a look. Okay, so what we're going to start with is our phase 1 of ankle sprain rehab. I've got a TheraBand with me. You can get TheraBand online for super cheap. I tied it into a loop. And the first exercise that we're going to do, so I'm sitting on my table. At home, you'd be sitting on your bed. We're going to say my left ankle is my sprained ankle. I tend to wear my shoes with this because the shoe tends to grip the TheraBand better and vice versa. I've seen a lot of people doing this with bare feet, and the TheraBand just seems to slip right off of them. So first exercise, I've got it around the foot. I'm looping it using the other foot to kind of create the angle of resistance. So hopefully you can see that with the camera angle. And what we're going to do is very simple. We're just going to go from here, and then I am resisting outwards, and I'm holding that for a 3 count, and I'm bringing it back. Notice that the range of motion is just coming from my ankle. What we don't want to do, a lot of people will kind of, if you see my knee in this, my knee is moving with it. You should look at your knee while this is happening, and your knee should not be moving. So this is your range. Out, hold it for a second or two, and back. Out, hold it for a second or two, and back. Now, I usually tell people three sets of 15 of each is usually a pretty good rule to follow. And this is a super good exercise for that, for the lateral collateral ankle sprain that you guys saw earlier in the presentation. Now, just to add a little note here, if you sprained your ankle the other way, if you sprained the deltoid ligaments, which is a bit more rare, you could actually create the angle from the other side like this, and you could slightly kind of go down it. So notice what my left foot and ankle are doing. Down and in. And you can do this exercise no matter which side of the ankle you sprain. You just got to be careful with the range of motion, because notice when you go into this range, you're kind of going into the range of a sprain for that inversion sprain. But as long as you keep your range of motion reasonable, you're good. So those are the 2 principal motions. And then you can also do, of course, just holding it straight up and doing ankle pumps. And then Kira, who's holding the camera, I'm going to make her hold this end. Do me a favor, hold this end. I'm just going to do a dorsiflexion. We'll see if you can get a good. So the last range that we can do is to just tie the other end of the band or have somebody hold it and then just resist upwards like that. So that's your 4-way. Fantastic. Next. And then the last exercise, obviously, you want to do with our shoe off. You want to find a hardwood floor, a linoleum floor. Take a seat. I'm putting my towel down. I've got my heel off the towel, and I've got my foot on the towel, like so. And then what I'm going to do is I'm just going to gather. And what I usually do is I do usually 20 pulls. So I go 1, 2, 3, 4, 5. I'm trying to get this towel to go underneath my foot. And this will really feel like the underside of your foot is working. So I'm using my toes to pull. And then once I've got about 20 of those and that's starting to feel tired under my foot, I reverse. Push, 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 push. So I usually go 20 pulls in, 20 pushes out, and do 3 sets of that as well. So the basic exercises that you just saw I would say I assign to patients for 1 to 3 weeks following that initial little acute phase where you're resting and icing and compressing and elevating. So use 1 to 3 weeks as a guideline. And use your judgment to see how you feel before progressing on to the next phase of exercises, which is in point number 3 that we have there. I will often use the 0 to 10 pain scale as a determinant as to whether my patients are ready to progress to the next line of exercises. If the pain level is let's say a 1 or a 2 or around that area with walking a city block, then in my opinion, the patient can start to add in some of these standing exercises. So realize here that you certainly do not need to add in all of these exercises all at once. You can kind of gradually go into it, pace yourself, see how you're feeling in terms of the pain, and then deal with that appropriately. So now let's take a look at our next video, which is the next tier of exercises. So this is our phase 2. So you completed phase 1, ready to move on to phase 2. The first thing that I will usually have people work on is getting back that dorsiflexion motion, that motion this way, which tends to get stiff with ankle sprains. And just very simply put, what I do is I'll start people in a seated position. And what they'll do, if the left side is our sprained ankle, I have them slide their heel back to such a point that it feels like you're getting that stretch kind of in the joint, right about here. This is not so much a calf stretch, although you might feel a little bit of a calf stretch, more of a joint stretch. And you want to be careful when you're doing this. A lot of people, when they do this, their heel will start peeking up off the ground kind of as a substitution. So if you can, hopefully you can see that heel position should be corrected. So if you're sliding your heel back and you pop up, put that down. And when you feel a nice little stretch, just stay there for about 10 or 15 seconds. I usually do that about 4 or 5 times. Now, how much range of motion is normal range of motion? Well, I will usually tell people that the majority of the time you can just compare it to your other ankle. So if you find that you're sliding both of these feet back and your uninvolved side goes back way further, then what you want to do over time is try to emulate that amount of motion that you can get with the unaffected side. So that's our first exercise. Second exercise, we're going to progress the TheraBand that we started with. And I'm going to pop my shoes on just because, again, I find that the rubber band tends to stick to my shoe better and it doesn't slide off. So these are toe taps. What I have here is a TheraBand that's it's been tied into a loop. I'm putting it around the end of my foot. It's important that you put it around the end. Don't put it around the proximal part. You want to go as far down here as you can without it slipping off. And what I'm doing is I'm keeping my body steady, heels on the ground, and I'm doing a good old-fashioned big toe tap, like that. Straight up and down, just up and down in that plane. You want to keep the motion in one plane. Usually about 15 or 20 of those are going to start to tire you out. You're going to feel it kind of on the outside of the leg, outside of the shin, I should say. So I'm going to go 20 that way, and then after that, I usually alternate. I'm going to immediately turn around, and I'm going to do the same thing this way. Big toe taps. Same idea applies. Isolate the motion at your ankle. Don't swing your whole body back and forth. Don't go through your hip. Think no movement in the body with the exception of the ankle. So we're going to go 20 that way. Next exercise. And for this, super important, I usually tell people, shoe off. When you do when it's time for you to tackle the single leg balance, your foot will work much more, and the ankle intrinsics and extrinsics will work much better if your shoe is off. So 3 progressions here. First one is flat floor. So you've got your flat floor. I'm going to unlock my knee so I'm not resting on my ligaments. And this is what I'm doing. And for this, I would use a timer. See if you can do this for 30 seconds. Now, if you are older or if your balance is otherwise compromised or something like this, you may want to, kind of do this next to a table. You got to make sure you're safe. If you don't know you're safe, ask your doctor. So, start with something like this. 30 seconds, or until you're tired around the ankle 3 times. When that's easy, we have a blue foam piece. You can get one of these online. You could use a couch cushion. You could use a pillow. Be creative about it if you need to. This is going to be harder. So I'm on it. Same idea applies. Knees unlocked. That's what I'm doing. And what I tell patients too, it's coming to mind, is that when your balance is perturbed, you're going to notice that your ankle is going to make little adjustments. Your ankle is usually the first thing to make adjustments when your balance is off. Your hip is usually the second thing. If you start flailing your arms around, it is time for you to put your other foot down. I'd much rather have you do this and then come back up onto it than try to be all competitive with yourself and see how far out of your center of gravity you can get without falling. That's stupid. So it's a single leg balance, knee unlocked, use your other foot as needed. Once this gets easy, I'm sure you've seen these in gyms. This is called a BOSU. I think I'm supposed to tell you that we do not get any payment for BOSU for using this. This is just something that we tend to use in the clinic, and I'm sure there are other products like this. But I'm stepping right on the bullseye. Whoa. So this would be kind of more for the athlete type. This is the single best bang for your buck if you only have time to do one thing long term to keep your ankle stable. So I put my foot down because I was starting to get out of my center of gravity. So progress up the ladder. If you're not an athlete, don't feel like you have to do this. You can just do the flat ground. Make it according to what your situation is. What I also want to show you here with our last little video are some manual medicine interventions that are typically done by a physical therapist and osteopaths, specifically for patients with a chronically stiff ankle that resulted from a sprain. So the techniques that you're about to see are not typically done immediately after an ankle sprain, but rather after some time has passed. And the idea behind most of these interventions is to get the stiff joint articulations of the ankle moving again more ideally. If your ankle sprain is severe enough that your doctor orders PT, you may want to ask your treating therapist if he or she can perform some of these manual medicine techniques to improve your mobility. In general, I would not recommend trying to have someone who is not trained perform these on you. And like I said, if you feel like your ankle is stiff long-term after your sprain, ask your doc if it would be okay to do some hands-on physical therapy. And one last little side note here, most doctors are not really trained to assess what physical therapists assess, such as the loss of the dorsiflexion range and the actual feel of the stiff joints that result months after a sprain has occurred very often. I've had a lot of patients who, in my opinion, could have really used some hands-on work, but their doctors tended to be a bit dismissive about it and thought that it really wasn't needed. I would say that if your ankle doesn't feel right a few months after a sprain, you need to be your own best patient advocate and either demand a prescription from your doctor for physical therapy, or in most states now, you can just go and get an evaluation from a physical therapist without a doctor's referral. And by the way, most responsible physical therapists will type up your evaluation results and send it off to your doctor and just have the doctor sign off of it. And that will act as a prescription unto itself. Last video, this won't take too long. I just wanted to present to you the idea of some of the manual medicine things that we do here, that we do as PTs, that if you end up having to actually have your ankle mobilized and moved because it's super stiff after a really bad sprain, for example, and you can't manage it yourself, I just want to show you some of the things that we do, just so that if you do get qualified professional care, that you can bring this up with them and kind of make sure that this is on the list of things for them to do. So here's our sprained ankle. One of the mobilizations that I will typically do is I'm going to pop this towel under your ankle. So here's the fibular bone. It's that you have these two long bones that come down. You have your tibia and you have your fibula. Fibula's on the outside, and remember that the ankle, the ligaments, the ATFL and CFL ligaments run along the outside here. In order to get this bone to move better if it's stiff, because sometimes it gets yanked a little bit with sprains, I will take my hand and take my thumb here, kind of my thumb web space in what's called my thenar area, and I am kind of wrapping around the front of the fibula like this. And then what I am doing is I am just applying a little bit of a backwards force, not a lot, as I move the ankle into this range. And then when I kind of let off the pressure, I bring it that way. So I'm just giving a little bit of a backwards motion to that fibula. And if it's done wrong on you, it doesn't feel good. So we do not want to take this bone and compact it into the tibia. I'm taking it, and my directionality is kind of like this. So I'm just kind of going in that range. This was originally devised by a guy named Mulligan, I believe, Mulligan. He was either Australian or maybe from New Zealand. If you check out his stuff online, he's got a lot of mobilization, so it's pretty neat stuff. So that's the first thing that I usually will do. In order to get a little bit more range in this part of the ankle, it can get very sticky after bad sprains. I will take both of my hands and just kind of interweave my fingers over like this. And then I just kind of put the foot in a neutral position. And now what I'm doing, hopefully without pulling you off the table, Kara, is I'm applying a little bit of a distraction or a little bit of a pull. And the range, I'm kind of pulling in this direction. And one thing, you can't see Kira sitting here filming, but when people do this, or when you're having it done on you, I tell people lie back all the way, because if they're sitting up and watching what's happening, they tend to stiffen up around it as kind of a defensive mechanism. Now, I am not pulling her foot off. I'm just doing just kind of a gentle distraction like this, but way more effective if the person is lying down and otherwise distracted. So those are two. Third thing that we usually do, just to make sure that all of the ankle is moving, is just a cup and a splay. So I'm kind of grabbing down near the metatarsal heads, and I've got her midfoot here, and I'm just splaying and cupping. There are a lot of joints in the foot, so the directionality of this, what I tell people is just kind of go with the flow. You shouldn't feel like you're going up against a brick wall when you do this. It's a cup, and hopefully you can get an appreciation for the direction that I'm going here, and a splay. It's not in one plane at all. This is very nuanced motion. So we got our cup and our splay. And then the last thing that I've seen PTs do that, for a lateral collateral ankle sprain that occurred a while ago, probably several months, you want to be several months past when it happened, is just taking a little bit of lotion on the finger and just kind of getting around that ligamentous area here. And then I just kind of do like a cross friction massage. And I'm going around. You can feel the end of the fibula. And I just kind of go around it. Don't rub right on the bone. That feels awful. So I'm just kind of hugging around like that. So hopefully this gives you an idea of some of the manual medicine stuff that you might want to have done if your ankle sprain is severe and you find months after the fact that you're still swollen or you're still stiff. Now, in wrapping up our presentation here, let's talk about long-term modifications that should be considered following ankle sprains. As we mentioned earlier in the presentation, the lateral ligaments will often become stretched out, especially with those of us who have sprained the ankle multiple times. I, for one, was a chronic ankle sprainer. I did lots of inversion sprains when I played competitive basketball when I was young. And I found that the stabilization exercises helped a whole lot. But in addition to the stabilization exercises, I found that I needed to wear an ankle brace while I was playing ballistic sports to keep me from respraining. So I would recommend for anyone who has sprained his or her ankle who plays ballistic sports or otherwise challenges the ankle on uneven surfaces, like with trail hiking, for example, that you should consider getting a low-profile ankle support brace for these activities. By low profile, I mean a brace that's not super bulky, that's super hard to get into your shoe. So I've listed a few of the braces at the bottom of the slide here, just from doing a quick search. These braces do provide lateral and sometimes lateral medial support. In my opinion, they're small enough to fit into most shoes. So I would highly recommend trying on multiple braces in order to find that good fit. After all, if you put this brace on and it feels awful, you're going to be less inclined to wear it, and what's the point? And one last little piece of info here in regards to this. Athletic trainers are fantastic at taping the ankle for stability. So if you are on a sports team, or if you play organized sports, if there is an athletic trainer available to you, many athletes actually prefer to have the ankle taped for stability rather than using a stabilization brace. Just something to think about. And as our final note here, our final slide, I wanted you to think about two things that you should consider either doing long term after a bad ankle sprain, or at least checking every once in a while to make sure that you don't have a deficit. The first is single leg balance. Now, as I said in the video, in my humble opinion, the best bang for your buck in terms of exercise for stabilizing the muscles around the ankle is single leg balance training. I have patients do this both with their shoe on and their shoe off to challenge the muscles in different ways. If you compare the non-sprained side to the sprained side with single leg balance, and you notice that it's harder to maintain balance on the sprained side, then you still have work to do, in my opinion. You still need to train that ankle, especially if you are playing sports. Get a foam pad or a Bosu. Most gyms have these. Use these to balance on and do your maintenance work. And the second thing that I would tell patients that they need to check is that seated heel slide exercise to make sure that the sprained ankle feels like it slides back in a comparable way to the unaffected side. If the ankle still feels stiff and stuck with that, I would keep working on that gently, and I would probably see a PT about it. Remember that that loss of that dorsiflexion range of motion can really mess up how the rest of your leg works all the way up the kinetic chain, all the way up to your hip. So if you're having a hard time with it, get it taken care of.